السلام عليكم ورحمة الله. تحياتي وشكرا على الدعوة. شرف لي. هذه أول مؤتمر نحضره لجمعية القلب الليبية للأسف، لكن إن شاء الله ما تكونش الأخيرة. My talk really is very brief and concise and really personal perspective. There's not science in it much. So I've added, as a privilege, two unusual short scenarios just for fun. Any questions, any queries, are prepared to answer even after the lecture on my email, or even if you want to call me. No disclosures, thank you very much. And this is the outline. The conclusion is a poem, really, with some words of wisdom, which I really think you should concentrate on that one. That's the most exciting for me anyway. So it is brief, it's concise, with reference to the use of cardiac ultrasound. And I call it cardiac ultrasound rather than echo, and you should know that later on. I came back from UK in 1985. After spending time in UK doing my undergraduate and postgraduate training and work, and I was the first pediatric cardiologist, hopefully everybody agrees, in Libya at that time. Now, just to go back again, from 1980 to 1985, the M-mode machine was there, available for adults and used at Hawari Hospital. It was used for children who was referred with suspected heart disease. So you see how difficult it is, and it was performed by adult cardiologists. Now, cross-sectional echo was not available at that time, and there was no trained, dedicated pediatric cardiology until my coming through. So in 1985 to 1988, I performed cardiac ultrasound using an available black and white abdominal ultrasound machine. And that's why I call it ultrasound, with cross-sectional mechanical transducer rather than the phased array. There was no color Doppler yet. And people were surprised because they were saying, this is abdominal ultrasound machine. I said, well, I'm doing cardiac ultrasound. It's the same principles. And everything was fine. I was getting to see patients and diagnosing cases and recognizing them and teaching. Now, from 1889 to 98, and at Salata from 1994, we used the newly available color Doppler as well with phased array. I performed an average of 700 selective echoes per year. I'm saying selective because only 5% of the echoes that I did were normal. So either we were picking up everything, or we're really missing the small things like small PFOs and whatever. Most of them were actually innocent of functional murmurs, but we may not be picking up mitral valve prolapse, for example. Now, training pediatricians and future pediatric cardiologists was established and was really my aim, stressing that correlative cardiology, correlate the clinical findings with simple investigation first and then doing the echo is vital. We should be clinicians, not just technicians, and that was our goal. In summary again, prior to 1985, no definitive diagnosis. After 1985, introduced the wonderful echocardography, which revolutionized cardiology as a whole, with improvement and accurate diagnosis, better management, timely referral for surgery, and long-term follow-up. Again, the opportunity led us to do cardiac surgery, bypass and no pass without prior cardiac catheterization in 87% of cases at Salata Hospital, in conjunction with Professor Hassan Maghou, which was not the usual practice in other cardiac centers, locally or even abroad at that time. Everybody had a pre operative cardiac catheterization, even with simple lesions like a ductus or an AST or a VST or a coarctation. The increase was from 1904 to 98 from 50% to 87% without pre-op cardiac catheterization. The success rate of acute diagnosis was 97%, which was high, I hope. There was no misdiagnosis. However, there was simple incomplete diagnosis, which did not affect the successful outcome or led to any morbidity, including, for example, finding a small AST or ductus with a mild coarctation. So it was not really something dramatic. Again, the very close collaboration with Professor Hassan Abdelmatlub as the sole dedicated pediatric surgeon then was vital and paramount for the progress of pediatric cardiology service in Libya. He actually took an opportunity to invite me there, and I used to go there a week per month from 1994 until 1998, before I left away to the UAE. Again, his surgical results, only 6.6% mortality. So it's 501 patients, 505 operations, 297 open, 208 closed, age 1 week to 69, which is a little bit high here. The mean age was 12 years. Now, this is the history, brief history, hopefully, and now we go for the fun. Brief quiz, asymptomatic newborn with central cyanosis. Everybody recognized central cyanosis. He's asymptomatic actually at that time, but if he was symptomatic, they will be in trouble. Everybody knows what to do. Even kids know what to do. Yeah? What do you do? Here we are. A kid knows what to do. Daddy is not here now, but you better start prostaglandin anyway. Now, scenario 1, in 1990, 11-year-old chest pain and syncope, brought in, not in distress, again, clinically nothing much, chest x-ray is normal, and 2D echo really gave us the clue. It was a small pericardial effusion and a large cyst embedded in the LV posterior wall. No other places. The cyst has a cloudy content. This is the long axis view. Obviously, there are some other pictures, but they've been lost. But this is the one that actually was published. This is the long axis view, LALV aorta. This is posterior mitral leaflet, buttressed by the cyst, which is quite thickened. And this is anterior leaflet. There was no mitral regurg. Pericardial effusion was aspirated and was strongly positive for hydatid. And albendazole was started initially for 4 months, but the child did not take, only continued for 3 months. The size of the cyst became thickened, and the hydatid sign was visible, clearly visible, but there was no other, no decrease. And the pericardial space was clear. Cardiac surgery was recommended, but it was declined by our home cardiac surgical team at Najura, and later by parents, and I've lost them after 2 years, no follow-up. This was published, clinical experience, cardiac arrest in a child in 1990. The next scenario, which is a recent one, interesting, again, from Tobruk, 18 months with mainly asymptomatic, although there is history of cyanosis according to mom, and referred with the echo diagnosis, and I'm making this as quite clear, echo diagnosis of mitral valve prolapse with mitral regurg and dilated LA. There was no clinical resume given, and the clinical clue was and is clear. SpO2 was not available at that stage. Does she look blue? She's wearing a pink dress. Well, there is a clue there, which is clubbing. It's very clear. So really, this is not a mitral valve prolapse, mitral regurgitant LA. This must be a cyanotic congenital heart defect. Situs solitus, AV and VA concordance, and this is the subxiphoid view, dilated LA, this is the intra-atrial septum, this is the SVC here, small RA and RV. This is a suprasternal short axis view, the sort of crabbed view, showing aorta here, RPA, LA, this is the SVC here, coming through into the left atrium. And you could see, this is the right superior vena cava, and this is again here. Now we look at the IVC. Again, the IVC and hepatic veins are entering into the posterior left atrium. This is the atrial septum is in here. So you could view this very interestingly. This is also IVC, hepatic veins entering to the left atrium. So total anomalous systemic venous connection. This is another view of the subxiphoid view to show you just the dilated LA, LV, intra-atrial septum, small RA. This is the tricuspid valve, and this is the small RV. So there is hypoplasia of the right side. And I thought at one stage, when I looked at this, I thought maybe could it be a core tracheatum dextra, core tracheatum dextra, but obviously it isn't. And this is the view here. So, diagnosis confirmed by cardiac CT was done in Egypt. This is a coronal section anteriorly, no left SVC. This is the posterior aspect coronal section showing the right superior vena cava, LA, IVC entering into the LA and the pulmonary veins. And this is a sagittal view, again, RA anteriorly, LA posteriorly, with both the right superior vena cava, IVC and hepatic veins entering the left atrium, with the pulmonary veins coming through here. Very, very surprised, but it was confirmed and they acknowledged that it was really picked up nicely. Now the diagnosis, total anomalous systemic venous connection in non-isomeric state plus ASD secundum, no persistent left SCC. So it's reported as very rare, exceptional, or very scarce. Persistent left SCC to coronary sinus to RA, most encountered anomalous systemic venous vein in 2.1% to 4.3%. Isolated right superior vena cava to LA is rare, reported rare, 20 patients reported, which is really interesting because this is a total rather than isolated right SVC. The first baby with total anomalous systemic venous connection I encountered, recognized, very important, diagnosed and confirmed. History and clinical assessment is always, should be the rule to diagnose. Cardiac surgery performed successfully in Egypt. Cardiac follow-up, excellent outcome of surgery with residual ASD, mild pulmonary hypertension, and reported laminar flow across, although I'm not sure about this. This is the post-op echo. Again, look at the dilated RA, RV, there's some paradoxal movement. And this is the ASD here, left to right shunting, and this is a pulmonary vein rather than the SVC. This is the SVC here, coming into the right atrium. So anybody interested in getting the surgical results will show you separately. Now, conclusion, echocardiography is fantastic. It is an investigational tool. The machine is good as the operator. Let us persist and continue to be systematic, practice correlative cardiology to reach an accurate diagnosis and plan of management. Finally, the last two slides, Medical Litany, a poem from 1953 from Professor Robert Hutchinson of the Hutchinson Clinical Methods classic book. From inability to let well alone, from too much zeal for the new and contempt what is old, from putting knowledge before wisdom, science before art, cleverness before common sense, from treating patients as cases, and from making the cure of the disease more grievous than the endurance of the same. Good Lord, deliver us. Ya Rab. I have translated this in Arabic. It's a personal translation. اللهم قنا يا رب من التدخل طبيا أو جراحيا بدون حاجة أو قدرة، ومن حب كل جديد وازدراء ما هو قديم، ومن إعطاء الأولوية للمعرفة لا للحكمة، ومن العلم قبل فن أصول العمل، ومن اعتبار المهارة أهم من التفكير السليم، ومن اعتبار المريض الإنسان حالة مرضية، ومن جعل العلاج أكثر ضررا من تحمل المرض. اللهم آمين يا رب، والحمد لله رب العالمين. وشكرا.